How are you guys doing?
Not bad. I doing fine.
We good? Give it a couple more minutes. We had a few technical issues, so apologies for that. We're running a little bit late, uh, but this session should run about 1 hour. Um, but I am quite flexible. But obviously, you can come and come join in as you please, and leave as you please as well. Today we've got a session on eating disorders. I do know that one of the members did request teaching for today's session. But I was very keen to do this one because in my coaching sessions, I would say this is probably the worst done topic by two doctors. So I think it's good to clarify everything, make sure all the members and everyone else knows what to do. Not that I'm a authority on this, but just remind people about what the guidance says and advises, and make sure that we are giving management plans in line with guidance because people aren't doing it. And I don't know why, because they do it in other topics, but in psychiatry, for some reason, guidance goes down the drain and people, Dr. Luna is here now, and people, yeah, they just get too shy to follow the guidance, I think, perhaps because we talked about we released like a short video recently on depression, and people aren't prepared to offer antidepressants for people with more severe depression, and they should be doing that. And if you are feeling a bit shy about, am I offering something that's outside of my realms as a junior doctor, as an FY2 doctor, then what you can do is you can say, our guidance recommends in your case, and then give whatever the first line treatment is. That way, the examiner can't argue with you. Yeah. You say what the guidance recommends, and you can just say, is that something you think you'd benefit from? Is that something you'd like to give a try? Is that something you'd like to discuss further? So that's the way to go about it, because I do sense that people are a bit shy to, because they just want to offer like talking therapy, just a generic counselling or something, and they don't feel like they're an authority or in a position to be able to offer some of these kind of like more advanced treatments. But just always signpost it by saying that this is what the guidance advises, and what do you think about that? And certainly, yes, eating disorders is one of those areas where people are not giving management advice in line with guidance, and they're just just generally not very well understood. So we're going to go through a bit of that background about eating disorders. We're going to cover everything today. We're going to do a quiz as well, which should be fun. So it'll be nice and interactive, this one. We'll do a quiz which is taken from the all-in-one approach notes, from the Smart Revision notes, on all-in-one approach on eating disorders. So it covers all the assessment and management of all the eating disorders that you're assessed in PLAB 2 on. Dr. Luna, are you there? Sorry.
Yes, I'm here. Can you hear me?
Hi. Yes. Hi, how are you?
I'm good.
And Dr. Lina, or camera's not working, or what?
Oh, I'm here.
How are you doing? You okay? Oh, it's good to see some friendly faces.
Yeah.
Anyway, yeah, shall we get into it?
Yeah, that's good.
Yes. Okay.
I think my camera
it
is
is.
not working. Sorry. I think my
Who's
camera
that?
is
Sorry.
not working. Well, I'm Sahwah.
Oh, right. Okay.
Okay.
Yeah, I think it's kind of coming in and out. Yeah, so we're talking a little bit about eating disorders. I mean, there was a request for teaching. I think that was quite a strong request that people wanted to do a session on, but generally teaching is done pretty well. It's done all right, but eating disorders and psychiatry, and I haven't done like a group session, on any psychiatry cases at all, and it's definitely the biggest gap in people's knowledge, I think. So yeah, I was really keen to do this one. Very sensitive topic as well, and yeah, so I think it's a good one to cover. We've got Dr. Lina and Dr. Luna here today. So thank you very much, guys, for taking your time. Congratulations, Dr. Lina, on passing quite recently.
Yeah.
Yeah. This one actually is a video appointment. So, Dr. Sahwah, who's going to be doing this case, so we do expect a little bit of an extra identity layer check. So all three pieces of information, and those will be provided when the timer starts. You will see that on the screen. So, do use that, Dr. Sahwah. And one more thing. I am going to be role-playing the role of a 16-year-old girl. So, I'll try my best. I wasn't able to entice somebody to come in and do the acting role, female. But yes, so yeah, forgive me if my acting is not very good.
Begin.
Hello, is this Emily Stratford?
Yes, that's me, yes.
Hi, Emily. I'm Dr. Hamad. I'm one of the doctors at the GP surgery. Can I ask you to confirm your name for me, please?
Yeah, my name's Emily Stratford.
And your age, please?
Yeah, I'm 16.
Okay, thank you, Emily. I see that your mom has made this appointment for us to speak to you. Do you know what this appointment is?
What it is?
Yeah.
Yeah, she was just a bit concerned because she saw me vomiting this morning.
Mm-hmm. She saw you vomiting. And when did she saw you you vomit? Was it this morning?
Yeah, just this morning, yeah, about 3 hours ago.
Okay. Is this the first time it happened?
Not really, no.
No, okay. How many times would you say per week?
A week. Oh, I would say maybe two or three times a week it happens, yeah.
Oh, okay, I see. Is it getting better for you? Do you think it's getting better?
Oh no, I wouldn't say it's getting better, no.
Mm-hmm. That's okay. And is there anything that might have caused you to vomit? Can you think of anything?
Oh no, just kind of happens.
Oh, okay. Did you have anything else with the vomit, like diarrhea or any other symptom?
Oh no, just the vomiting, yeah.
Okay, good. So Emily, I think sometimes after having a large meal, people can feel uncomfortable, and then they would, in order to get rid of this uncomfortable feeling, they can make themselves sick. I was wondering if that's something that you have experienced.
Yeah, I mean, what do you mean by uncomfortable, doctor?
Uncomfortable, you feel like you're full, or you have this sort of feeling that you're guilty of for eating a large portion of food. Have you ever had this feeling?
Yes, that's exactly what happens, yes.
All right, okay, I see. And have you ever lost control on how much you eat? How much?
Oh yes, yeah, that happens to me quite often,
That's
yeah.
feasible.
I'm on a bit of a strict diet, so sometimes I have what I call relapses.
Oh, okay, see that. And mm, recently, have you lost more than a stone or 12 pounds? Almost like more than 10 pounds.
Yeah, I would say I've lost I would say about 1.5 stone over the last 3 months.
All right, I see. Emily, Emily, do you sometimes feel sad when other people shake your chin?
Yeah, I mean, they say, my weight's fine, nothing wrong with my weight, but yeah, I'm disgusting. I hate looking at myself in the.
You feel like, okay, I understand that. Right, and does food generally dominate your life? Do you feel that food dominates your life?
Yeah, I do think about food quite a lot, and have
Mhm.
different techniques to
Mm.
minimize the amount of food and to avoid temptations.
Oh, okay. Um, all right, Emily, just more questions. Do you know how much you weigh?
Yeah, so I weigh 50 kilos.
All right. How do you feel about your weight? Do you have an ideal body weight?
Yes, ideally I'd like to be 38 kilograms really,
38,
like that.
okay. Around that. And your diet, what do you eat in breakfast?
First I have a salad.
Salad? What
Um,
about mhm,
yeah.
all day or just anything else other than salad?
Yeah, lunch I have a salad and dinner I have a salad as well.
Hmm, okay. Um, all right, Emily. So do you sometimes have this? You said you eat a lot of portion of food. Does it
Oh
happen
yes.
when you're alone, or do you have friends around? You do the same?
No, no, no. I don't like eating with people. No,
All
it
right.
happens alone. Yeah.
Okay. And after that, what do you do? Do you vomit that amount of food, or do you do what do you compensate the exercising? What do you do after?
Yeah. No, I just vomit. I feel terrible, and so vomiting. Yeah, that
Mm.
helps.
Have you ever tried to use any sort of medications to get rid of the food?
No, nothing like that. No.
All right. Emily, sometimes in the midst of life, people can feel overwhelmed, and that might make them think about hurting themselves or that life is not worth living. Have you ever thought about this?
Oh no, 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 no. I had any thoughts like that. No.
2 minutes remaining.
That's good. That's good. Have you ever had feelings that you're about to faint or that like blackouts?
No, no.
All right, that's good. Just some standard questions. When was your last menstrual period?
Say it was 2 weeks ago.
Mm-hmm. I see. So, Emily, thank you for answering my questions. I'm just going to examine you. I'm going to measure your weight and height and do a standard called BMI. Okay, and also would like to take your temperature, measure your blood pressure. Would that be okay?
Yeah, yeah, that's fine.
Thank you. And also would like to do some um, test for your heart racing. Okay. And so, Emily, based on what we've discussed, this is most likely a condition called bulimia nervosa. Have you ever heard about this?
Oh no, no.
Right. So it's a condition. It's an eating disorder when people tend to eat large amounts of food and then they would try to get rid of this through vomiting or exercise. And this is called purging. Okay. And it's not a normal eating pattern. It's really serious and it can cause a lot of problems. Right, Emily? So what we're going to do is going to refer you to a mental children special mental health services. Time is up. Children.
Okay, so
Move on to the next station.
tell me if you had, another 30 seconds or so, give me an overview of what your management plan would be. So you talked about referral to the children as
Yeah,
mental health services.
specialist
Anything
services.
else?
Mm. And also, I'm going talk about the therapy so that they will offer her a focused family therapy where they will talk about her eating pattern and how to
Mm-hmm.
improve her well-being. And also run some basic investigations to make sure that everything is okay. And I would advise her to keep an eye on her food and maybe provide leaflets. Yeah, at the last thing I would provide leaflet on the eating disorders.
Yes. You see how you gave a nice overview there very quickly within, that was probably about 20 or 30 seconds that you said all
Mm,
those things. So all you needed to do was just give yourself an extra 30 seconds and you would have been able to get your management marks, all of those things. Um,
yeah.
so I think like you need to be a bit more vigilant with the time. I think you were a bit too late to recognize that you were running late. I think I was looking at the timer, when you were, doing the general health stuff, the screening for amenorrhea and stuff like that. I think at that point, you should have recognized that I need to start prioritizing a little bit more. I'm being a bit too much of a perfectionist when it comes to my data gathering, and I'm going to suffer in my management, which is what ended up happening, right?
Yeah.
So I think that was the main thing, because otherwise, the consultation was excellent. Your bedside manner, it's a video appointment, but your demeanor with the young girl was very good. It was excellent, in fact. So I was very keen to give you that information quite early on. Generally, that's what they'll do, right? Is basically, depending on how non-judgmental, sensitive the doctor is, they will volunteer that information. If you don't do a good job of asking asking those kind of questions, then they won't give it to you, and you'll end up having to get it right at the end, and then it has a knock-on effect on your management plan. But there's two main things I would say, right? So obviously we talked about time management. So that's it's difficult to come back from that, obviously, right? The second thing is you screened a bit too early on. You needed to screen for some DDs. So I would say they were the two main things that stood out for me in terms of what you could do to improve this case. Number one is you need to be more vigilant with your time, because you're too relaxed, too detailed data gathering. You don't have that luxury, especially in a psychiatry case, because they're very wordy consultations, and so you need to get to the point. You need to make some sacrifices. Focus, on the key themes only. This is why I tell people that you should always summarize, 3 or 4 key points in your data gathering, so that you do not move on until you've asked those specific questions or got those specific findings in your history or examination. That way, anything else that's not one of those key themes, you just have to sacrifice and just not ask it. You don't have time. So it's a very time sensitive exam, and in particular psychiatry station. So definitely do that, because that gets a lot of people, isn't it, with the data gathering. But yeah, otherwise, it was excellent. So yeah, that's kind of my notes on that. Anyone else at all? Dr. Lina, Dr. Luna?
I just would always recommend not skipping out on the open questions, because I feel like
Yes.
always give you, especially in the exam and in the real circumstances, going into the station, I would always be a bit nervous, but once I said my open questions and they volunteered some info for me, I was like in my zone, and I can go off what they say or what they said.
Yeah.
So yeah, it's good not to skip on them.
Yes. And so some examples of open questions, right? So, talk me through what's been happening
Tell me
recently.
more about this vomiting. Yeah.
Yes. Tell me more about this vomiting. Describe to me exactly what happens. Yeah. So there's some examples. And it may be that they don't volunteer that any information, but at least you gave her the because they want to assess what kind of close questions you're going to ask, right? Because that's how you demonstrate your understanding. But you need to still give them the opportunity to volunteer information through open questions, which is very important for a patient-centered consultation.
Because sometimes they do, so you never know they're going to volunteer this info or not, so you might as well just ask it. And it also helps you get into the groove of things, and it comes easy that way.
In terms of your selection of closed questions, it was excellent. I mean, there's nothing that you missed out at all. It was almost too, it was too detailed there. You needed to strip it down a little bit more, just because of the sacrifices. In an ideal world, that would be like perfect data gathering. There's nothing else that I would have added, apart from, what Dr. Lina's talked about in terms of the open questions and the DD questions before you start screening for, because you screen for eating disorder straight away. Remember, like, we don't know that this is an eating disorder, right? I know that this case, we've packaged it as an eating disorder session, but in the exam, they don't come with an diagnosis on their forehead, right? Which obviously, don't forget to adequately screen for other potential causes of this vomiting, which are what, by the way? What potential causes could there be? What things should we screen for in this young girl?
Bulimia, ketoacidosis might be.
Yeah, so bulimia, and then what was the second one? Diabetic ketoacidosis. Yeah.
I
Yeah.
think gastroenteritis and maybe Addison.
Yes. Gastroenteritis. Addison's? I wouldn't. I mean, Addison's wouldn't be. So I wouldn't be thinking about Addison's. Addison's a very rare condition. That would be, very low on my list of differentials. Anything else, guys? But yeah, certainly the first one that you mentioned. Gastroenteritis. Yeah. Got common things first, right? And then a few serious things, like the other doctor mentioned, DKA.
Also, I think in these cases, it's very important to rule out pregnancy as well when someone is very young. So I think it's important to mention that as well.
Yes, yes, and also, requesting a urinary pregnancy test. Oh, she did say that she's her last menstrual period is 2 weeks, so it's unnecessary in this case. But if she said, because she's lost a lot of weight, that she hasn't had her period for 1 or 2 months, sorry, like over a month, then it might be worth, and she's sexually active, then it might be worth doing a pregnancy test, because you don't know what's causing this. Is it because she's lost weight, or is it because she's pregnant? So it's always have a low index for requesting a urinary pregnancy test. A very rapid, straightforward test, isn't it? Anything else, Dr. Lina? Sorry, I forgot to ask you.
I think your interpersonal skills were very good. Again, it's good to start with the open-ended questions and to rule out the differential diagnosis first. I think it's also important to not rush into the management, because you had like 30 seconds just to talk about all the management. I know that sometimes we don't have the choice, but I think you could have like shortened the very targeted questions and went straight to the management when you see that you are lagging in time. And it's also important in that case to mention some blood tests that you might do and to mention some food supplements that the patient might need as well, I think.
Yes, we've got about blood tests. That's an important point for sure. In particular, urea and electrolytes. Because this is a not vomiting, video consultation. So you can't examine them there and there. You can't do a clinical examination or take bloods there and there. But what you should do is, ask them to come in. Yeah, definitely. These eating disorder ones, you need to examine them. So if there are telephone or video consultations, you ask them to come in. And if it's a face-to-face, you do need to do a clinical examination and you need to do blood tests in the GP surgery setting, even though you're referring. And you need to follow them up as well. If it's a child under 18, you need to follow them up every weekly, to screen for these complications. Yeah, so this is just an approach, my suggested approach, and it's just a suggestion. So I understand that your mother had some concerns. Can you take me through what's been happening recently, right? So, they might have mentioned in the task, did they mention vomiting? Okay, they mentioned vomiting. So what's a mistake that some people make is they say, oh, I see you've been vomiting. Can you tell me more about the vomiting? Right? That's their first open question. No, it can be more open than that. Take me through what's been happening, or take me through what's been going on. You see, it's basically asking nothing, right? It's just inviting them to, so that if there is anything that they wanted to volunteer outside of the vomiting, then you get that information. But if you don't do that, then you won't get it. And then, always like describe to me what happens exactly. That's always good. A good open question I find quite useful. You'll find that useful as well in like dermatology stations as well before you start doing your closed questions. But yes, time management is very, very important. I remember when you get to psychiatry, I want you to remember be hyper vigilant with time. Combined stations and psychiatry, time should be on the forefront of your mind. Yeah. So Dr. Sahwah, she was a bit too relaxed there. She should have been thinking more about time. And she has the luxury here of, because screen share is open, she's got the timer, the exact time. In the exam, you only have 2 minutes remaining, right? You only get the verbal prompt. So, you've got that chance there. And then, yeah, so we explore it briefly, basically. And then, like Dr. Sahwah did very, very nicely, she, screened for eating disorders, beginning with this first question here, the sick one. Ever make yourself sick because of feeling uncomfortably full or feelings of guilt or shame? And then from there, you can ask the others. But what was missing here, which was DDs, right? Where is it? Okay, so it's not in here. Okay. That's probably why she didn't ask them, because they're not in my notes. I need to add those. For some reason, I'm sure they should be on there. So there is an association between eating disorders and particularly so anxiety spectrum of disorders, right? So OCD in particular, general panic disorder as well, and some of the social withdrawal, social phobia and stuff, and also deliberate self-harm by scratching and cutting in particular, and obviously depression. Yes, so we do the SCOFF questionnaire. Ever made yourself sick because you feel uncomfortable before, or because of feelings of guilt or shame? Ever lost control of how much you eat? That's another thing that people often forget with bulimia, is that they get the finding that they self-induce the vomiting, but they forget to ask about the other half of bulimia nervosa, which is the binges. Yeah, and as well as the other compensatory mechanisms as well. Not just, there could be screening for them, which Dr Sahwah asked very nicely. But what often people do forget is the binges, and then they say, "I think you've got bulimia nervosa," but you need to, to get a good provisional diagnosis, you need that other finding as well. And timings are important as well, so it needs to be at least 1 week for a period of 3 months or more. Yeah, 1 stone, which is equal to 6.35 kilograms. I know that most people probably aren't familiar with stones, that kind of imperial system. And then, do you believe you're fat when others think you're thin? Would you say that food dominates your life? You get 2 or more positive ones, then we proceed. So really, this is a mistake in the notes. The DDs should come here, right? Alongside the SCOFF questionnaire. Then when that's positive, then for eating disorder history. So we're going to ask about the weight, which Dr. Sahwah did ask. And remember, they can falsify their weight, right? So do you still measure it in the examination? Yes, and this is another thing I often find in coaching with this case, is that people don't ask what you eat. What do you eat on a regular day? Take me through your diet. What's that like? On an average day, breakfast, lunch, and dinner. What do you eat? People often miss that, and it's like an eating disorder. You haven't asked them what she eats. So don't forget to the basic questions, guys. Yes, body image dysmorphia, role models and stuff like that is nice. Find out what her kind of idea of an ideal body shape is. Yes, the bulimia specific questions. So the binges and purges, which primarily is the self-induced vomiting, but other things as well. So laxatives, diet pills, diuretics, insulin, the diuretics, over-exercising, fasting, all those kind of things. Yes, and very important because it's an exam, so physical and psychological. So don't forget, I know it's a psychiatric case, but with eating disorders, so you want to screen for physical complications. So funny turns, dizziness, faints, heart racing, all those kind of things. It's nice to get into the habit of, using terms that are more familiar to patients, to, lay people. I wouldn't use, things like palpitations, even though palpitations most people would understand, but it's better to describe it as a sensation of your heart racing or something like that, or thumping, something like that, and tummy pain as well. Yeah, so the criteria is for bulimia nervosa is that both the binge eating and the compensatory behaviors occur each on average at least once a week for 3 months. So Dr. Sahwah asked me specifically about that, how many times a week, and that's a very important question to ask. Right, so this is a bit of a source of confusion for people, is BMI in bulimia nervosa, because they get confused because I give them the finding of a normal BMI, and then they're like, oh, what is this? I don't know what it is now. It can't be an eating disorder. No. So bulimics more commonly have either a normal or raised BMI. Yeah, sometimes they're quite chubby, actually, right? Because they're having these binges so frequently. But they can also have a low BMI as well. Anorexia, on the other hand, is always going to be low. Yeah, and then yeah, general health questions. So the ones I wouldn't want to miss here. She's 16 years old, so school performance, type, concentration, a drug history, and insight, if you can. That's always a good one to ask in these psychiatric stations. Nice. if you ask insight, that covers you for ICE as well anyway. Anything else at all, Dr. Luna, Dr. Lina?
It's just that insight is really important in all psychiatric stations. I'm not really sure if she asked it here, but generally asking the patient if they think they need the help of their healthcare professional or something like that in psychiatry, I think it's very important.
So someone's asking, it's crucial to ask all of SCOFF?
Dr. Hashim, if you get stuck in that data gathering or any of the psychiatry station, how would you move forward? Would you like mention in detail? Because I wanted to do the examination. I was stuck in the examination, so examination and then diagnosis and management. So how would you approach this if you run out of time?
Just to clarify what you mean, so you had a list of certain things that you wanted to include within your data gathering, and you weren't sure what to cut out and what to include. Is that right?
Yeah.
Yeah. So because it's an exam, you want to always lean towards things that compromise patient safety, right? And so red flag symptoms and signs, right? So you ask the symptoms, which is good. But in terms of investigations, especially if they're inducing vomiting or they're using laxatives, those two, then you need to do U&Es, right? So that's one thing I want to include that Dr. Luna talked about, because we always lean to what's going to kill this patient. What's the worst that can happen with this patient? Well, the worst that can happen is that she dies of hypokalemia from a cardiac arrhythmia, or she kills herself, right? So you asked me about. I think syncope you asked. Maybe just group the symptoms together so it doesn't waste time. Practice that so you get into the habit of asking those groups of questions quickly. But yeah, so I would lean more towards the things related to safety. So the investigations, the basic observations which you included, they're like the main things I would say in terms of examination and ECG.
It's just sometimes in most of the stations you would be stuck in the data gathering. So even if there isn't an examination, you would find yourself 2 minutes and you haven't discussed with the patient. So I know the management points are important, but you haven't mentioned what's bulimia. So I was thinking, can I just say that this is bulimia and then use my 1 minute to discuss the management or explain bulimia, because you never know if the patient is familiar with the bulimia or not. How to tackle, what to choose.
Yeah, just give a brief explanation. Yeah. 1 or 2 sentences. You can't get yourself into the situation, basically, right? Because we're talking about what do you do if you get yourself into the situation. Well, just don't get yourself into the situation where you have to make unacceptable sacrifices with your time. Yeah, like you're telling me, oh, do I have to explain the diagnosis of bulimia? Well, yeah, you're assessing her. You need to tell her what the diagnosis is. But what we really need to focus on instead is how do we trim down our data gathering so that we don't get ourselves ever into this situation. Yeah. That makes sense?
Yeah, fair enough.
I mean, I told you how I would. If you were in that situation, I would lean towards the safety stuff, right? In terms of in your history and examination. So those red flag, physical and psychological red flag symptoms, as well as the physical blood test and ECG, that kind of stuff. They're the ones I would quickly include and then move on to diagnosis and then give a brief overview of management. So in terms of the diagnosis, it was a very nice explanation. So binges and purges. So it could be eating disorders, right? So it's not just anorexia nervosa, bulimia nervosa, there are other eating disorders as well, right? For example, binge eating disorder. So there's binges, but there's no purges. But because you got both findings, so you can say bulimia nervosa. Suspicion, it's always a suspicion, guys. So, when you read the nice CKS guidance, they always separate conditions into suspected and confirmed, right? So make sure you're orientated. If it's a first presentation, you've not got sufficient findings yet. In this case, because this is a psychiatric condition that requires diagnosis by a specialist, so you're not in a position to formally diagnose at this stage. It's diagnosis made by a specialist, so it's still, just a suspicion. But in other cases where you need to do blood tests or specific investigations to diagnose it or biopsy, then it's always suspicion. And then don't be too confident. Yeah, so these are the key themes, right? So she gave a very nice overview, but albeit it was after the time ended, she did mention the referral within the time, which is the most important point. If you're going to mention one, that's the one to mention. And then, yes, you need to get them to come in. You need to assess them, do a clinical examination, and do some blood tests that we talked about, you know, and ECG and stuff like that. Yes, and this is the one that if you don't have time, you know, this is the one I would sacrifice. It's the advice, and yeah, if you've got time, you know, talk about regular. You know, I'd like to see you on a regular basis or on a weekly basis if possible. And safety net, you know, please, you know, do come back or, you know, seek urgent medical attention if, and then list the red flag symptoms, physical, psychological, and then, you know, leaflets. You can mention that, you know, you give them in when they come in some reading information, or you can just tell them the name, but that's not important. The main things I want you to focus on here, right, are the referral, which is to the children and young people's mental health services. Within there might be some branches, you know, eating disorder specialist there. Yeah, so, you know, people aren't referring to the correct place. This is an under 18 year old. Any suspected eating disorder under 18, you refer to the children, young people's mental health services, right? If they are an adult, so they're 18 or over, then you would refer to the specialist eating disorder unit, right? So let's make sure we're referring to the exactly in line with the guidance. It's not like a big deal. Like if you say specialist eating disorder unit and they're under 18, it's not going to fail you, right? But show them that you are reading the guidance, yeah, because it will improve your management works. Yes, we talked about the follow-up advice. Yeah, I mean, so dental erosion, right? So, you know, if they're brushing their teeth straight after they've self-induced vomiting, then that's going to make it worse. So they need to rinse their mouth with water or with a non-acidic mouthwash. That way, you know, it won't further erode the teeth because it's, you know, it's an acidic environment that's been created by the vomiting. Yes. Okay. So that's the main things, I think. And then we've just, you know, we've included some of these details here. These are just the details if you have time. So, you know, what the specialist will do, it's not, this is a more of an assessment focused station. The most important points to get in your management here is the provisional diagnosis, the referral, and the face-to-face follow-up, right? You get those in, you'll pass the station more or less. You know, assuming that you screened properly for red flags and stuff, you did a decent history. And then, you know, so see, these are some of the details. So do make sure that you are familiar with what the first-line treatments are, which we'll talk about with the quiz for these different conditions, which is based on, you know, the type of eating disorder and also the age group, okay, because it varies according to that. In this case, she's under 18 and she's suspected bulimia nervosa, not anorexia nervosa, and so it's bulimia nervosa focused family therapy. But generally speaking, right, any eating disorder, they're under 18, first-line treatment by the specialist will be a family therapy, and that's always the case for childhood psychiatric conditions. It's always family therapy, right? So if you're not sure and it's a psychiatric condition like autism, you know, a young person, and a psychiatric condition, ADHD, for example. But obviously, if they're young people, then you can't really do CBT. Sometimes you can do adolescent focused CBT, which we'll come on to in a second. But yeah, so in this case, under 18, eating disorder, family therapy. Yeah, so we talked about these. So the important ones I don't want people, you know, don't want you to miss are the cardiovascular ones, right? So BP, heart rate, those two, very, very important. And obviously the BMI and the ECG, and then the blood test, the UNEs, right? So we've underlined, you know, the most important ones there. Probably they won't give you too many issues to manage because it's a psychiatry station, it's very time sensitive. So they probably won't give you that there's a sexual health issue here because otherwise you just won't have time. So, you know, so she's not sexually active and she's had a period recently. Yeah. So you don't need to worry about that. That's not applicable. But the dental erosion one is one I want you know, if you've got time, that's a good one to talk about. Yeah. And then, you know, safety net. And then for eating disorders, BEAT eating disorders, it's called BEAT. That's the UK's leading eating disorder charity. So, yeah. Might as well mention it. There's no harm in mentioning it, but if you don't, obviously it doesn't matter. Yeah, so that is the management plan. And these are the indications for admission, right? So split it into biological, psychological, and social, which can affect, you know, cause physical complications or psychiatric or psychological complications, right? So, so the biological ones, so, you know, like we talked about with the cardiovascular complications, instability, postural hypertension, or postural tachycardia, all that kind of stuff. Anyway, we won't go into too much detail. Risk of refeeding syndrome. So that's why we request phosphate. And that's why BMI less than 16 is an indication for medical admission. Yep. So remember, medical admission is psychiatric admission. If there's physical red flags, either based on symptoms, they've got palpitations, they've got funny fainting and stuff like that, they need to be admitted to a medical unit, right? Not a psychiatric unit. Or any of the investigations are positive, the ones that we talked about. And psychiatric if they've got suicidal thoughts, self-harm. And social as well, so which can put them at risk. So if the household is not appropriate and it's not conducive to a good recovery, then that's an indication too. Yeah, that's just a summary. So how did I score you, Dr. Sahwah? Are you still there, by the way? Sorry,
Yeah,
I've
of
been talking a long
course.
time.
No, of course.
Yes. Okay. Like Dr. Lina said, IPS was actually, yeah. Dr. Lina, what do you think? How would you mark her?
So actually, the IPS, I would give her 3. Yeah, and the data gathering, I would also give her a 3. And the management, I think she wouldn't really pass because she didn't have a lot of time, but overall, I think she did really well. I have one more thing to say. When going into the consultation, I felt like it was a bit awkward at the beginning because she said, do you know what it is? So I think when you go in, the first thing you say or you do, because this is how I found it in my exam, if you went in and you were smooth, it translates throughout the consultation. So maybe just have in mind when you're outside for like a minute and a half, think about how what's the first thing you're gonna say, because it really matters the most.
Yes. Oh, yes. Certainly, first impressions. You can't make a first impression again, and it tends to have a lasting impact for sure. So, Dr. Sahwah asks, if the patient already admitted to inducing it herself, why do we have to ask for the differentials? Which will further waste time. If the patient's already admitted to inducing it herself, why do we have to ask for the differentials? No. So what I was talking about was she asked the question too early. She should have screened for other differentials, because someone who presents with vomiting, your first instinct isn't necessarily, oh, this is an eating disorder, is it? You're going to, ask some questions. You're going to, like they, do gastroenteritis, you've had a fever recently, you had this, you had that. You're not going to jump straight to, do you stick your fingers down your throat, right? So that's the point we're getting at there. So, you need to ask that first. Then later on, yeah, I agree in that once you've got that finding, you don't need to explore anything else there. You pretty much know what it is. Does that make sense? Hope that makes sense, Dr. Sahwah. I would completely agree, by the way, Dr. Lina, in terms of the marking. IPS is 3. So in terms of your actual IPS is good. It's just time management. You can't score somebody full marks for IPS if they stop abruptly. And then data gathering, yes, a 3. There's an argument for giving it 4, actually, I would say. Management, you explained, the condition nicely, and you refer to the appropriate specialist.
I gave myself 2 in management.
Yeah, and you did fit in the investigations, didn't you? You did that as part of the examination, right? I think you did the examination, but you didn't do the investigations, right? Yeah, I mean it's borderline 1 to 2, isn't it? Yeah, I think 2 is maybe a little bit generous, perhaps, but certainly in this kind of mock scenario, I would probably, in my coaching, I would give you a 1 for management, just because I want you to pay the price for it so that you don't do it again, so that it re-etches that neural pathway a bit harder, so that you don't make the same mistake again. Yeah, so that's very good. Thank you very much, Dr. Sahwah, for volunteering. In terms of the feedback statements, yeah, so the main ones really are time and management, which obviously, because you didn't have time. Yeah, everything else was great. So I would give you a tick for those two. Primarily time, because it's, you know, time is the main one. Yes. Try and do
I
this
just
quickly.
wanted to emphasize on one thing. Sorry, my camera is not working anymore.
So,
So the issue here was not actually in the management itself, it was mainly in time management. So I think that's something that you should learn to practice in every station, because the more you practice that, the better you get at it. So I think time management is key, and you really don't like, you really have to focus on not rushing into the management specifically, because most people tend to do that. And it's really important to remember that it is a very important and big part of the whole station.
yes. Yeah, absolutely. Yeah. So, you know, people often, they get their marks, right? They get their, you know, they sit the exam, and they get their marks, and they look at the total scores for each of the 3 domains. And then they see their management and they say, oh, my management's the lowest, so my problem is in management. No, your problem very often, sometimes it may very well be in management, which is, you know, that's knowledge, really. That's where knowledge comes in. But very often what it is also the fact that they're running out of time and not giving themselves enough time to manage a patient properly. So, you know, do be aware of that. It's, you know, if it's going to have a knock-on effect on everything, and it'll have a knock-on effect on your interpersonal skills marks as well. So really, it's a fatal mistake. So you need to, this is the importance of practicing. People who don't practice, they often do run out of time, because that you need to exercise that muscle of prioritizing, yeah, taking a focused history. And really, there's 2 things you need to do in order to do that. Number 1 is you need to summarize key points in data gathering as well as management. And number 2 is you need to practice under time conditions. That's why on my website, you know, we have a timer there. That's to prompt you, this timer here, right? That is to prompt you to use it when you're
Begin.
studying. Yeah, so there's a timer there.
Enter the room.
So use that, guys, when you're practicing. Do make sure you keep your learning active, hence the name of PLAB2, you know, MLA cases, PLAB2 cases. That's the slogan. Yeah, try to keep it as active as possible. Yes, and so another way of keeping it active is by doing quizzes. So let's do a quiz. So let's do, this is in the all-in-one approach notes for eating disorders. Do guys, do go through the eating disorders, sorry, the all-in-one approach notes, because you know, the curriculum is so vast, you probably won't have time to go through each individual case. So what we've done is we've grouped them together. Yeah, apart from the new cases, which we've done separately, we've grouped them together so you can go through all the cases for each consultation type, for each station type in one go, so that it's more efficient for your learning. Yeah. So that you study the approach, and then within there, embedded within there, is specific details related to each individual case, right? So it saves you a lot of time. So do go through these all-in-one approaches. Yeah, so let's go through this quiz. So these are the quizzes. You'll find these in the all the lessons. Right. So let's get some people involved. So what is a possible red flag requiring emergency admission to a psychiatric unit for patients with eating disorders? So if you could put your your answers in the comments, guys, in the chat box. By the way, these quizzes, sometimes there may be more than one correct answer. Okay. So what do you guys think? What's a possible red flag requiring emergency admission to a psychiatric unit? Dr. Sahwah says suicide risk. Anyone else? Yes, suicide risk. Yep. So notice the key point here is psychiatric, which Elizabeth's fallen for, right? I was hoping somebody would fall for that trap, right? Because it says psychiatric unit, so it's a bit of a trick question, right? Yes, hyperkalemia is an indication for an admission, but admission to a medical unit. So that's the correct answer. Right, question 2. What is a possible red flag requiring emergency admission to a medical unit for patients with eating disorders? Chronic headache, abnormal blood tests such as electrolyte imbalance or hypoglycemia, cardiovascular instability, so bradycardia, tachycardia on standing, hypertension, and risk of refeeding syndrome, e.g. BMI less than 16 kilograms per meter squared. All right, so remember, I did say there's more than one correct answer in some of these, yeah? So what's your answer or answers Okay, people are just listing one thing, and clearly there's more than one correct answer, right? You're not going to not admit her if she's got cardiovascular instability and risk of repeating syndrome. So the answer is yes, Elizabeth, absolutely right. B, C, and D. These are all indications. These are all, physical to a medical unit. Any other indications, physical indications? Any physical symptoms, basically, right? So syncope, postural hypertension, palpitations, you should admit for those as well. That indicates cardiovascular instability. Which of the following actions may be a compensatory mechanism for binges in bulimia nervosa? So excessive exercise, excessive sleeping, eating more, laxatives, and self-induced vomiting. So Dr. Sahwah says, okay, Elizabeth says B, C, D. Sahwah says B and C. Simplet says A, C, E, D. Yes, A, C, E, D, yeah. Absolutely right. Any others, by the way? Any other compensatory mechanisms not mentioned here? Fasting, diet pills, diuretics. Yeah, that's pretty much it. So when you do your past drug history, medication history, ask them, follow up your question with, over-the-counter medications as well. So say you're on any medications, or do you take any medications on a regular basis, including over-the-counter medications? Yeah.
Dr. Hashim, how is eating more is compensation for binges?
Which of the following actually? Yes, you're absolutely right. Yes. So eating more can't be, yeah. Eating less would be perhaps fasting. Yeah, absolutely right. So yes, that's correct. Sorry about that. What is the recommended first-line treatment for anorexia nervosa in individuals under 18 years of age? Right. So this is where people go wrong, right? So what do you think, guys? Who's reading the guidance? Or who's reading my notes? What does Dr. Simpson says? A? Yes. So we talked about basically any psychiatric condition in children under 18s, family therapy. Yeah. They're not old enough for CBT to understand it. Unless they're adolescents, in which case, there is adolescent CBT. Yeah, that's correct. So what is the recommended first-line treatment for bulimia nervosa in individuals under 18 years of age? Come on, guys, this is an easy one. We've just covered it. Yeah, family therapy. Yeah, as with most psychiatric conditions in children, always family therapy. So these ones are a bit more tricky. So what's the recommended first-line treatment for bulimia nervosa in individuals aged 18 years or over? This is one where often people go wrong. Yeah, so the answer here is actually guided self-help. Yeah, bulimia-focused guided self-help program, bulimia. So basically, I'll keep it very simple for you guys. Under 18, psychiatric condition, including eating disorders, family therapy, first line. Over 18, if it's anorexia, actually we won't. Yeah, if it's anorexia, it's the psychological therapies. If it's bulimia, it's self-help program. Yeah, these are the first line treatments. So, therefore, this one, which we've just talked about. So what treatments may be offered first line for anorexia nervosa in individuals aged 18 years or over? So the answer there is the psychological therapies. Now the choice of three that you can discuss with them. So in this one, it's a choice of family therapies that include like Mosley's mantra, CBT, and specialist support clinical management. But yeah, it's a choice of psychological therapies, and you can offer like CBT or something. So all of these three are correct, but not family therapy because that's under 18s. What types of tests may a specialist request to check for complications related to eating disorders? MRI, PET scan, ultrasound, ECG, blah, 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 blah. Yeah, I'm sure you can tell which is the correct answer. That's very obvious. We've covered that today. Yeah, so the answer is number 2. Ones not to forget, ECG, UNEs. Yeah, obviously you can do FBC. She's anemic and stuff, of course, but, UNEs, perhaps phosphate. These are the three, and glucose. Yeah, these are like 3 or 4. As long as you mention the main ones, 2 or 3, you'll be fine. Select one or more correct answers. What is or are appropriate services to refer individuals under the age of 18 with a suspecting eating disorder? Children and young people's mental health services, children's health team in hospital or pediatrics department, specialist eating disorder unit, or community mental health team. So Dr. Ketmi says A. Yes. So just like we said, always under 18 is family therapy, and it's always as well for eating disorders. It's the children, young people's mental health services. If you say eating disorder unit, it's fine, all right. But let's get our brownie points. Show that we're reading guidance, giving management in line with the guidance. Oh yes, sorry. This one, yeah, Dr. Simper, well spotted. It's also this one as well. Sometimes it varies depending on locality, but these are the ones that the guidance mentioned, both of them. Select one or more correct answers. What is appropriate service to refer individuals age 18 or over with a suspecting eating disorder? So over 18. Yes, Dr. Simper, absolutely right. C and D. Yes. Dr. Simper's done the quiz. He knows. Excellent. So that is how you manage in line with guidance, eating disorders. Yeah. So do make sure, and show them that you're managing in line with guidance by saying our guidance recommends that in your case, because you are under 18, over 18, for patients with bulimia nervosa, first line treatment is, and then you can say, self-help guided program, for over 18, for example. Yeah. So that's the quiz. And then nice guidelines. Yeah, we are running out of time, so I think we're just wrapping up now. Do make sure, guys. Okay, I'm in Krakow at the moment, so I'm outside the UK. So I can't access it unless I open a VPN. But yes, guys, do make sure that you do open a VPN if you're outside the UK, and that you read it. Yeah. But if you've read my notes, then you're covered anyway. So I've done all the research for you. Okay. Right. Thank you very much, guys. It was very good. Very nice. Thank you very much, Dr. Sahwah, for volunteering. Thank you very much, Dr. Luna, Dr. Lina, for sparing some time to join the session. I think Dr. Luna has been having a few technical problems with her laptop.
Thank you. Yeah, sorry, the camera stopped working, but I'm still here. Thank you, everyone.
Thanks, guys. Are you still there, Dr. Lina?
Yeah.
Thanks again, Dr. Lina.
Well, thank you.
Thanks again, Dr. Luna. Good to see you guys, and thank you again, guys. We're going to do another one very soon. We'll try and do them every, on a regular basis, these sessions. So do let us know. We do have somebody, Dr. Simplet. He has reserved the next slot, right? So he's got that one. So no one else can volunteer for the next one, but certainly if you want to do any of the subsequent ones, then let me know. Yeah, thanks very much, guys. I'll leave it there, and happy Halloween. Take care. Bye-bye.
Thanks, everyone. Happy Halloween.
Thank you.
Bye.
Bye.
Bye.